So good morning and welcome everyone to today's webinar, which will be focused on how the Innovative Health Initiatives projects have an impact on cancer. My name is Oussama Karoum, and I'm Scientific Officer at the Innovative Health Initiative, or IHI. We are delighted that you could join us today for the next 90 minutes to hear from our panel of distinguished speakers. As you may know, the Innovative Health Initiatives projects are cross-sectoral public-private partnerships that work together toward the same goal, which is to address unmet public health needs that one sector in isolation wouldn't be able to tackle alone. So before moving on to the webinar itself, just a few information. Please be informed that this session is being recorded and that the recording will be made available on IHI's website and in our IHI YouTube channel. At any time during the event, if you have any question to our speakers, please use the Q&A box at the bottom of your screen. So before moving on to the project presentations, I will first make a short introduction with a few figures about cancer epidemiology, so that to try to quantify the burden of cancer worldwide and specifically in the European Union. Then I will briefly present the IHI oncology portfolio before moving on to the project presentations. And today we will have 4 project presentations, which are Pioneer, Optima, GuideMD, and Imagio. So first, a few figures about cancer epidemiology. So according the Global Cancer Observatory, today in 2022, there is 20 million new persons which are diagnosed with cancer every year at the global scale. And unfortunately, the situation is not going to improve in the future because projections from the Global Cancer Observatory shows that there will be an increase by almost 80% by 2050 to reach an amount of more than 35 million new cases being diagnosed with cancer every year at the global scale. Looking specifically at the European Union, according to the European Cancer Information System website, there is 2.7 million new persons diagnosed with cancer every year in the European Union. And the most common type of cancer being breast, colorectal, prostate, and lung cancer. What does that mean in practice? In practice, it means that 1 in 4 women and 1 in 3 men are expected to be diagnosed with cancer before the age of 75 in the European Union. When it comes to mortality, 1.3 million persons die from cancer every year in the European Union, with the most deadly type of cancer being lung, colorectal, breast, and pancreatic cancer. Likewise, it means that 1 in 11 women and approximately 1 in 7 men are expected to die from cancer before the age of 75 in the European Union. These show us how cancer is an unmet public health need, and that's the reason why the Innovative Health Initiative has launched many projects to tackle this unmet public health need. So now I'm going to present briefly the IHI cancer portfolio. So this slide here shows the list of projects which are working on the most common type of cancer worldwide, starting with lung at the first place. We have 6 projects, IHI projects working in this indication. At the second place, we have breast cancer, which is the second most common type of cancer worldwide, and several projects working in this indication. We also have a few projects working on colorectal cancer. And at the 4th place, we have prostate cancer with 5 IHI projects focused on this indication. We are not only, we don't have only projects working on the most common type of cancer. Our portfolio covers 14 cancer indications altogether, from the most common type of cancer, as you have seen in the last slide, to more rare cancers such as sarcoma, brain or ovarian cancers, and others, as you can see on this slide. Obviously, we will not be able today to speak about all these projects and cover all these indications. So we have decided to focus today on 4 specific projects, which are covering 7 cancer indications. These projects, as already mentioned, are Pioneer, Optima, GuideMRD, and IMAGIO. So let's start now with the first project presentation, which is Pioneer, which is a project focused on prostate cancer. And to do that, we have the pleasure to welcome Susan Evans Axelson. Susan is the General Manager of the European Association of Urology, and she was also very much involved in the Pioneer project as the project industry lead. Susan, the floor is yours.
Great, thank you very much. So, like Osama said, right now I'm going to focus on the Pioneer project. And Pioneer is an IMI funded project consisting of, we have 36 stakeholders across 9 countries. And if you look at the date, we were launched in May 2018 as part of the Big Data for Better Outcomes initiative based solely on prostate cancer research. And we're a 5-year project, so we were 2018, and we actually ended in October, the very end of October 2023. And so from here, I will show you how Pioneer is now moved from Pioneer into its sustainability and how we go forward. But Pioneer project itself, it's based on prostate cancer, and we have this particular focus on, we wanted to improve the prostate cancer related outcomes, health system efficiency, and the quality of care and health and social care across Europe. So we've already looked at some of the statistics, but now we're going to focus more on prostate cancer statistics. Cancer itself is a major health issue. Prostate cancer is a major health issue. In 2021, we had the European Commission set the overall economic impact of all cancers to exceed 100 billion annually. But if we look worldwide, prostate cancer itself is the 2nd leading diagnosed cancer and the 5th leading cause of death. And then if we go to European level, it is the most common cancer diagnosed among men and the 3rd leading cause of death. So it's still a major health issue. And what are our challenges? Well, with all cancers, our challenges are screening, diagnosis, and treatment. We know with prostate cancer, we have an insufficient knowledge of the risk factor and patient characteristics. Who's going to get cancer? What does this patient look like? We know we need to integrate real-world data into these disease classifications. But we're collecting all of this real-world data, but we still have a lack of standardized definitions on these core outcomes. And that's because we lack stratification. If you can further, yeah. If we lack the appropriate stratification of these patients. So how do we separate these patients so that we can really see how they are getting treated and how they are responding in the real world? We have insufficient meaningful engagement with stakeholders, and this includes our patients. So we need to get better at stakeholder engagement. And we know that we also have this suboptimal care of the prostate cancer patients that needs to be addressed. So what are our goals in treating prostate cancer? Well, of course, your biggest goal would be to improve survival. But a man with prostate cancer just doesn't want to be alive. He wants to be alive with a good quality of life. So we want to improve survival. So we want to treat these men and give them minimal treatment-related side effects so that they maintain their quality of life. And by doing this, our goal would be to identify the right patient when they get the treatment at the right time, but also with all of the treatment options, we need to know what sequence to give them in and the timing that they're given. So the Pioneer platform itself, it has data from over 3.5 million prostate cancer patients, and it is using data that's collected routinely. So not just in clinical trials, but also in academic and clinical settings. So you have this real-world data that's being collected. You need to put it in a common language so that you can really start doing these big data analytics and you can start generating this evidence. So you have your real-world data, you can generate your real-world evidence so that you can start to improve the process of developing medicines, treatments, and the research around prostate cancer. So now I'm going to talk to you about a few of the achievements within Pioneer. So the first thing that we needed to do within Pioneer was we needed to actually identify what are the gaps in knowledge for prostate cancer patients. So we got together clinicians and patients, guidelines groups specific for prostate cancer, and we identified 56 research questions They were then ranked based on what a clinician and the patients, based on what clinicians and the patients felt were most important. And then we formed research teams to help answer these questions. So we have 14 traditional research teams that were formed, but then we also had 3 international large studyathons. So studyathons are a really fun way to answer research questions. They are with our studyathons, we had 5-day hybrid virtual during COVID times, but these are focused multi-day meetings where we get everybody together in a room and we really focus on one research question and generate this medical evidence to go forward. So you put together all of your clinicians, researchers, data scientists, patients, and you really start to hash out and answer a research question to go forward and be able to answer. And here's some of the questions. Here's the questions that we tackled in the studyathons. The first one was around conservative management. Now, this is kind of hard for patients to sometimes understand. If they're told, okay, you have prostate cancer, but we're not going to do anything. We're just going to watch you. So do we delay or do we treat the cancer? And that's what we wanted to answer. If you go back, Osama. Yeah. And that's what we wanted to answer with this first studyathon. So sometimes, even though prostate cancer is the second leading cause of death, sometimes curative and treatment is not what's right for this man. Because with prostate cancer, you can live a happy, healthy life with the cancer and never need treated. But it's very hard to know and to have a clear understanding when to recommend conservative management. So within the Pioneer project, we had data from over 500,000 prostate cancer patients that we used to identify what were the most important factors that should be considered when deciding treat this man or conservative management, watchful waiting of this man. And we were able to recommend factors that the clinician should consider when deciding which treatment to give. So for the second studyathon, we went even further and we started looking at who benefits the most according to these treatments. And we're looking here at metastatic patients. And if you go forward one, we had a lot of data that came out of this. So we decided that we were going to separate this project into 2 different papers. So the first one, we wanted to focus on what are the baseline characteristics of men with metastatic cancer. So what do they look like when they're initially diagnosed with metastatic prostate cancer? We then wanted to look at paper 2, where we're looking at the treatment patterns. So now we have the man at baseline. What exactly is he getting prescribed? What is he treated with? What is his sequence of treatments? And then what are his clinical outcomes of these treatment sequences? And we're looking at 1, 3, and 5 years of these men so that we can really look at, okay, men with metastatic prostate cancer are diagnosed here, they're treated here, and this is the outcome. So one of the outcomes that we got for the baseline characteristics was that, if you go forward one, was that men who are diagnosed with metastatic prostate cancer are actually older and have more comorbidities than a man that you see in a clinical trial. So the evidence in real world shows that the man is much older than what's being introduced or being enrolled in clinical trials. So the average age of a man with metastatic disease is 68, and the average age of a man in a randomized controlled trial is around 65. So these are things that need to be considered. We then go further into studyathon 3, and we wanted to look at, okay, in these men with metastatic prostate cancer, what are some adverse events to these systemic treatments? And for here, what I'll focus on this is the cardiovascular adverse events. And what we're showing with this real world data, studyathon research question, was that men in the real world, so real world patients, they have a higher comorbidity burden at treatment initiation, meaning there's more that have diabetes, they're obese, they have more, they're on more medications effectively. And cardiovascular adverse events are extremely common they're common in the real world setting, so these should not be overlooked. And what we were able to show with all of these research that we're doing and the data that we're showing was that there's substantial heterogeneity across data sets. It's very hard when you're looking at 20 different data sets to be able to compare them. So what we wanted to do, we start seeing all of this that's happening, and we start seeing, okay, this is what's happening in a randomized controlled trial. These are the men, and this is what's happening in the real world. So being able and just thinking this is happening is one thing, but being able to actually show it with real data and real world data is a different thing, and it can really help to change how people think and organize. So what we wanted to do now, and this was not a study-a-thon, this was a question that came as a result of the research, where we wanted to look at how the generalizability of randomized controlled trials versus real-world evidence. And what we were able to show here is that the randomized clinical trials, the generalizability is limited by their strict exclusion criteria. So this results in findings that are limited, and they're based on highly selective group of patients. And we're looking solely at newly diagnosed metastatic patients. So these are limitations that should be considered when the clinician is prescribing treatments that are actually recommended based on clinical randomized controlled trials. So another thing that we had an achievement to focus on is the Pioneer core outcome sets. Like I told you a few minutes ago, there's heterogeneity on these trials. And what it is, you need these outcomes so that you can actually start comparing trial data, clinical data, anything that's collected. So if you go forward one, so why is it important? Again, if you have two trials that you're looking at, everybody's collecting their own outcomes. So it's like looking at apples and oranges. You really can't compare these. So if you go forward, one. So we have these core outcome sets, these Pioneer core outcome sets, and they were developed with patients and with clinicians. So we have the clinical reported outcomes, but also patient reported outcomes. So why are these important? These are going to, when you have these trials, when you're collecting any data, if we're collecting at a minimum these core outcomes, then we're able to start looking across data sets and collect apple and being able to look at apples versus apples instead of apples versus oranges. So this helps guide the healthcare profession into the adopting more effective patient relevant treatments quickly, but also helps safeguard against biases. So the next achievement that I can focus on for Pioneer is an online search tool. So in Pioneer, we developed the diagnostic and prognostic online search tool. So this is important because there are a number of biomarkers available that can help select patients for specific treatments, but knowing which one to use is sometimes hard. So we've developed this online search tool. If you go forward one, we have an online search tool, and you can go in and you can set in a diagnostic or prognostic factor. So here I searched for PCA, prostate cancer antigen 3. So what you do is you put this in, and then it brings up a list of publications related to PCA3. It can be a lot of publications, so you can actually narrow it down more. So you want to look at it and you say, okay, I'm looking at PCA3, but I want to see it pre-treatment in a high-risk patient. And then it narrows it down even further so that your clinician can really dig in and see, is this the right biomarker? Is this the right marker to use to choose this treatment? So it's a very nice tool that should be used a little bit more, I think. So within Pioneer, we've identified these research questions and started tackling them. We've developed these core outcome sets that I hope are used more for anyone that's collecting data and that they're used within the randomized controlled trials on outcomes. We have these search tools, but also what started in the foundation, what started within Pioneer was the conceptual development of the clinical decision support tool. So the good thing with this is that we form the foundation for this. And if you go forward one, I'll show you a little bit of what it's about. So within Pioneer, we started the foundation, and this is actually continuing off in the Euro Evidence Hub. And this is a patient experience engine. And what it is, it's a way to help the clinician see how are other patients just like you treated and what are their outcomes. So they put in you're the target, And then you want to find as many patients that are similar to you as possible. You want to then look at what treatment did they have, what sequence did they have, and what were their outcomes. And then you'll be able to look at this, and the clinician and you as a patient will be able to go through and say, okay, based on these other 1,000 men that look like me that had this treatment and these outcomes, I can recommend this. So this serves as a support tool to help find similar patients to you to see how their outcomes. Now, like I said, we started the foundation of that in Pioneer, and we are now in Pioneer Plus, which is under the Euro Evidence Hub. And what we're doing, we have Pioneer, where we started to identify these gaps, define the clinical needs. We started to gather the data, harmonize it so that we can use it for research. And then we moved to Pioneer Plus, where we're looking at more unstructured, so live data like electronic health records, integrating more AI, and doing this empirical patient decision support tools on that. So within the Euro Evidence Hub, it's not just prostate cancer will focus. It will be urological diseases. And we have the foundation of Pioneer, but also what you're about to hear is Optima, which is also building on this. So within Pioneer, we started this research-based platform, and now we're going even further. We have the Optima project, which you're about to hear about, and this takes AI to another level, and where we're also adding prostate, lung, and breast cancer. So thank you.
Thank you very much, Suzanne, for this very clear, insightful presentation. And you made the transition to the Optima project, which is the next presentation. Unfortunately, Professor James Endo couldn't join us today and had to cancel. But fortunately, Suzanne is also working and involved in the Optima project. So Suzanne will be presenting Optima on behalf of James Endo. Suzanne, if you may.
Yes. Thank you. Yes, he gives his apologies for that, but we're going to go forward with Optima. So how we go with Optima? Optima, we're looking at more because we're looking at prostate, breast, and lung cancer. So what we want to see is that we know that there are challenges of cancer patients globally, and that there are global solutions that we need to find. We know that there's 90% of the content in these scientific publications is really deemed unreliable or inappropriate for making changes in clinical practice guideline recommendations. And we know that several EU member countries, that there's approximately 4 out of 5 patients do not get access to evidence-based treatment for specific urological cancers or cancers. We know that the situation increases the likelihood of adverse outcomes, that it leads to these unnecessary complications, it incurs additional cost, but also there's a risk of providing potentially harmful care. So all of this needs to be considered. We know we're building on all of these projects, and we know that by expanding this real-world evidence efficiency, that we have the potential to boost research and answer these current questions on a global level. That we know that when we have these publications that are based on centers of excellence, that they're not always representative of the general practice everywhere. And we know that there's key subgroups that are often not represented. So the elderly, people with multiple comorbidities, obesity, ethnic minorities are not getting considered. So we really know that the data and real-world evidence, that they're great game changers that need to be harnessed. Go forward. So what I'm talking about here, I talked about one type of tool in Pioneer, but here we're talking about living guidelines. And by incorporating living guidelines in real-world evidence. So then we're able to have an interaction between clinicians, patients, and caregivers. So by having these living guidelines, we can improve quality of care, we can strengthen the role of shared treatment decisions, empower individualized treatment recommendations and care plans that consider physical, emotional, and psychological patient needs as preferences. And then we can look at this in context sensitive, so high income versus low income countries. Go forward. So the Optima project. Optima project is 21.3 million euro EU Innovative Medicine Initiative project launched in October 2021. And like I said, this is 3 forms of cancer we're working with: prostate cancer, breast, and lung cancer. And our vision here with Optima is that we really want every patient, they should have access to the most up-to-date and individualized treatment and to innovative therapies. And we do this with our mission because we want to design, develop, and deliver these interoperative real-world oncology data and evidence, this platform that can generate this real-world evidence that on the onset is based on the needs of the clinician and the patients in an inclusive and sustainable way. So we are a strong alliance of public and private partners. For Optima, we're 38 partners across 13 countries. We have the European Association of Urology as the public lead, and Pfizer are the private leads. We have patient groups, professional medical societies, AI and healthcare, and all coming together to be able to work on this and make sure that we have the expertise and effectively the expertise and the people behind us that can support. But we have this whole huge consortium, and we all have these consortiums that are focused, but how are they focused and what can a patient expect out of Optima, from Optima? So for one, with the Optima project, we can help to improve treatment decisions. So we're starting to integrate more of this AI. We're starting to more automate things that were manualized, that were manual before. So AI-driven decision support tools that help clinicians and patients to make more informed decision choices on how their treatment pathways. Access to cutting-edge research. We now have patients who are going to benefit from these new knowledge generation through advanced analytics and AI models. This leads to better recommendations, these live guidelines. And then we have personalized care, so that the platform is going to integrate electronic health records, so live data that's changing and updating so that we are updating the information. And this really allows for us to individualize treatment plans. But we need to make sure that we have access to the right data. So Optima has secured access to data covering over 200 million people. This is really great. Like I said, we have electronic health record data from people in Europe and in the US. We have data from biobanks, cancer registries, cohort data from patients in Europe. And then we also have trial and prospective cohort data participants available. So this makes, like, from generic guideline recommendations to truly individualizing patient care driven by data. Go forward. So within Optima project, like I said, we have prostate, breast, and lung cancer. And fortunately, a lot of the foundation that's moved forward to Optima was based on Pioneer. So we're not reinventing the wheel. We're going forward, we're learning, and we're building. So when I said in Pioneer that we identified and prioritized the research questions, we've done the same for breast and lung cancer. But another difference that we did, though, was that we assessed the quality of existing guidelines for all cancer types. And then we're starting to build these cancer pathways that are commonly used by clinicians. And these are extremely complex that you're going to see in just a minute. So by identifying the research questions, we're able to identify these gaps. And within it, we're asking questions like, what is the best clinical outcome for this treatment sequence? What's the BRCA mutation rate in a metastatic breast cancer patient? Can AI help to detect treatment-related adverse events? So these are all types of questions that we're answering. We're finding the data. We're using the data to really use real-world data to generate these real-world evidence. Go forward one. So this is a very complex slide, and this gives you a great indication of what a clinician is going through when he or she has a patient come to them with cancer. So you're looking at mapping for diagnosis and staging. So from diagnosing to staging, it's extremely complex. You need to track their imaging results, their lab results, patient factor. What does the patient want? So you have this, and within Optima, we're forming these. So we're creating these detailed treatment pathways to support the clinical decision. So we're building this clinical decision support tool that is going to help simplify this pathway so that you can really have this information all in one spot and choose the best treatment with confidence. So here's what it's looking like. we have here where we can put in clinical information. So this is a prostate cancer patient. So we say, okay, what's his PSA? You put in his PSA value. Do we have a Gleason score? We put in his Gleason score, and then we click forward, and we're very nicely able to give, we're given a treatment recommendation calculated automatically. So for instance, for this patient, his treatment recommendation was active surveillance. So that goes back to the treat or don't treat. So this is a very nice, easy tool to use. And we're going into AI. We're really starting to automate things and make them easier to go forward and be able to make these recommendations, not only for the clinician to be able to recommend them, but also for it to be better explained and so that the patient is educated on what's happening. So we're, like I said, we're starting to integrate all of these projects. We're building on each other, and now we're integrating more AI. So what is the impact of AI in cancer? So if I look at this, and again, I'm going to focus on prostate cancer. What's the current application of AI in prostate cancer? Well, detecting cancerous growth. AI system, it can accurately tell the difference between a harmless lump and those that might be cancerous. Also, better than the human eye. Advanced computer programs, they can analyze these medical images, and they can sometimes catch small details more reliably than a radiologist because they're able to pick up these fine details that we're not really able to catch right now. Also, smarter slide analysis. So when you take a tissue sample, you put it on a slide, and a pathologist will need to look and circle and look under a microscope. But now we can automate this, and doctors look at this tissue sample under a microscope. Your AI tool can really interpret these slides more accurately. So it means that it's relying less on a person to just look at a slide, and we're able to not have to go forward with as much details after other tests. So what are the future directions and potential? So personalized oncology. This is a great thing because everyone's an individual. You don't know how it's going to work, so we need to personalize it. So we want to ensure that you're receiving the right treatment at the right time in the right sequence. Also, automated workflow automation. Now, if we're able to automate a lot of stuff that's done manually now, like looking at a tissue slide, then it really frees up your healthcare professional to focus on your patient care, and it reduces the repetitive task. Also, predictive modeling. We want to really empower healthcare providers to be able to make quick decisions, so that they can fine-tune treatment as your condition changes. But also decentralized diagnosis. We want to make these cutting-edge diagnostic services accessible to communities where traditional healthcare is limited. These facilities are limited. So we want to really drive AI-driven mobile and telehealth platforms that can improve this early detection of treatment in low resource settings or underserved populations. So Optima itself, a large consortium, it's going great. We have a lot of people working together to really help to revolutionize oncology in Europe. To personalized, Optima will personalize treatment with these clinical decision support tools so they can leverage the synergy of real-world evidence and traditional clinical trials to deliver this personalized care. And also transformative insights with expandable AI. So we want to really harness expandable AI to uncover these novel insights for early diagnosis and treatment of breast, prostate, and lung cancer. So with that, I want to thank you for both Pioneer and Optima and going forward. So thank you very much.
Thank you very much, Susan. Thank you for the two very clear and insightful presentations today on Pioneer and Optima. We've learned a lot. Just to remind the audience that you can ask questions at any time using the Q&A box at the bottom of the screen. We are already receiving some questions that we will answer at the end of the webinar. So now moving on to the third project presented today. It's GuideMRD. GuideMRD is a project focused on liquid biopsy. It will be presented by Professor Klaus Pantel. Klaus is a world-renowned expert in liquid biopsy. He is the director of the Institute of Tumor Biology in Hamburg. Is also the founder and president of the European Liquid Biopsy Society, and most of all, is the academic coordinator of the IHI Guide MRD project. Klaus, the floor is yours.
Thank you very much, Usama, for this kind introduction. I think we can already go to the next slide, please. What is liquid biopsy actually? Well, 15 years ago, Katrina Lix-Banabier and I defined liquid biopsy as the analysis of tumor cells in blood and other body fluids. But very quickly, this term was also adopted for the detection of tumor-derived products, in particularly DNA fragments, microRNAs or extracellular vesicles that are released from tumor cells into the blood and other body fluids. And recently we have also included the analysis of host cells, because also the patient host actually determines what happens with tumors. And in the blood you have circulating immune cells, endothelial cells, fibroblasts, a lot of different cells that can fight or support the tumor cells. So what is the rationale? Why do we need it? Well, tissue biopsy with a needle is the standard procedure for cancer diagnosis, but it's invasive, and some of the locations, for example, a tumor in the lung or in the brain, are difficult to access. In contrast, drawing a blood sample is very simple, and we call it minimal invasive. Moreover, the blood is also a pool of tumor cells and their products that are released from primary and metastatic lesions from different parts of the body, and they all end up in the blood, so it seems to be a good source. And last but not least, we can take blood samples every week, every month, so we can get sequential analysis, and we can use that for real-time monitoring of what's going on with the tumor. We call it tumor evolution, and also whether the patient responds to the therapy or not. So together we get more comprehensive and real-time information by the analysis of blood or other body fluids. Next one, please. So we were very happy that between 2015 and 2019, we had an IMI funded project focusing on liquid biopsy with the name Cancer ID. And we were 40 partners supported by 80 million euros. And it was very successful with more than 50 scientific publications. And at the end of 2019, we thought, how can we go on with such a successful network and how can we sustain it? Next one, please. And we established actually our own ongoing network, which was called the European Liquid Biopsy Society, and which has been very successful because we have now over 90 institutions from academia and industry, similar to the IMI project, which was also composite of industry and academic institutions. And the key goal is now the clinical implementation of liquid biopsy, because there's a gap between many fantastic publications, but very little ends up for the patients in the clinic, and we want to close that gap with ELBS, which was initially supported by an IMI project. So we have different working groups on dissemination and education of what's going on with liquid biopsy. What are the clinical questions that are relevant in the clinical working group? What are the technologies that can address these clinical questions in the technology working group? What are the regulatory hurdles to bring these blood tests into the clinic in the regulatory group? And then also new groups on data computation. You heard also something about AI, which becomes more and more important. And also we include the patients in our patient advocacy group. And we are still open to new partners. If you're interested, let us know, please. Next one, please. And of course, what are the outputs and achievements, scientific publications? We can approve technologies and assays that can be used for certification of laboratories. We have published white papers. We are going to publish best practice SOPs. We have, of course, established research collaborations across Europe, but also to North America and Asia. Clinical study guidelines. We have actually been able to get new research grants. And I will talk about one that is, of course, the Guide MRD. And we also talk to healthcare coverage and reimbursement stakeholders, which is important to get tests into the clinic. Next one, please. So the one that we are now coordinating is this IHI project Guide MRD, which is really at the core of our interest in the liquid biopsy field. the question here is really how can we detect relapse in cancer patients earlier with a blood test, earlier than the imaging is able to do it. The project runs for 5 years, started 2 years ago with a total contribution of 35 million, or costs of 35 million. It's also a public-private partnership. You see also the private partners here listed on that slide, which I think is fantastic because we need private-public partnership to bring diagnostic into the clinic that cannot be done by one of those partners alone. So what are the objectives? We create standards and benchmark liquid biopsy assays. We want to see which assays is really good for clinical practice. Then after we do a robust clinical validation, and we have 3 model tumors: colorectal cancer, pancreatic cancer, and lung cancer, all tumors with significant risk to relapse. And then we want to integrate these blood tests as decision tool to guide treatment selection. The next one, please. So what is minimal residual disease? Well, actually, after the initial treatment, surgery or radiotherapy or adjuvant chemotherapy, you may have still tumors left over in your body. And this is a small number, but it can add up to hundreds of thousands of tumor cells in the whole body, which are totally undetectable by current radiological imaging. So what we can now do with the blood test, we are much more sensitive to actually pick up these cancer signals from the blood at a time when the imaging does not see anything. And this higher sensitivity gives us now the chance to act earlier, maybe even to be able to still cure the patient which has this minimal residual disease. Next one, please. So the key analyte, liquid biopsy biomarker, is really for this purpose in the IHI GuideMRD project, the circulating cell-free DNA. These are DNA molecules released from dying tumor cells, but there's also an active way to actually release them through little vesicles. So there are 2 methods to detect the DNA. The DNA derived from the tumor is diluted in a big sea of normal DNA from normal cells. So we have to find really out what is the contribution of the tumor. And there are 2 methods. The first one is that we take the tumor tissue, we sequence it, we get the genomic information, and then we design very specific probes for each patient individually. And this has a very high sensitivity. The second method does not require any tumor. We just actually detect the genomic aberrations that are known in a specific tumor. So we have a good guess from the literature. But of course, here the good thing is that we do not need the tumor tissue, but this has usually a lower sensitivity. What are the challenges? We can create false positive, and we want to avoid that because there might be normal cells that also have cancer associated aberrations. We may have false negative because some tumor lesions may not shed the DNA as others do. And of course, we have very low concentrations, goes down to actually below 0.001%, so very low concentrations in early stage disease and in the stage of MRD because we only have few tumor cells left over. So what are the aims and objectives of the GuideMRD project? Objective 1 is we want to benchmark the available assays. So we want to make sure which of the many commercially available assays are the best for this purpose. Then we want to rank them actually and test the candidates that are most successful, most promising in our clinical studies on lung, colorectal, and pancreatic cancer. Then we actually want to see what is the utility of these tests as a prospective decision tool in future clinical trials. And we also have, of course, a contact to the key stakeholders that are relevant for the implementation of ctDNA into clinical practice. Next one, please. So these are the clinical studies in GuideMRD, which are a cornerstone of our project. we have prospective observational clinical trials, which mean that we really take the blood samples and then see what happens to the cancer patients in colorectal, in pancreatic, and in lung cancer. Then at the end, we compare the best results that we achieved with the standard, the gold standard at that time. And we design a small randomized interventional trial where we detect MRD in the blood, and then we change our treatment based on whether we detect or not the MRD in the blood of these cancer patients. Next one, please. This is just a scheme showing what we really do in clinical practice. We collect actually blood samples before surgery, but most importantly after surgery and after adjuvant therapy to see are there some cancer cells left over? Is there still a cancer signal in the blood, despite the fact that we have done surgery on the tumor or even radiation or even chemotherapy, there might be tumor cells left over. We can measure that with this sequential blood analysis, and we also follow up these patients over time. And the key question is, which technologies are the best to detect the MRD as early as possible, most likely many months before imaging can do this. The next one, please. These are actually showing the strong collaborations within the Guide MRD project. We have, of course, strong collaborations between the different work packages. I don't want to go here in the detail. I explained already the objectives. I think we also have, of course, world-leading academics and industrial partners which are able actually to bring this technology into the clinic. Then, of course, we actually have co-leads in all work packages. So we are working closely together between academicians and the industry here. And I think what is also very important, we have two very active patient advocacy organizations that gives us really the input from the patient side. And with the synergists, we have a strong multi-stakeholder engagement. So we are not really working in a bubble, in an ivy tower, but we are working in the real world together with the other stakeholder relevant to bring these tests into the clinic. Next one, please. So in summary, early detection of minimal residual disease or relapse requires very sensitive assays. We detect the tumor burden to see how much tumor cells are left over, but we can also molecular characterize the tumor cells by the DNA measurements, and that might be very important to decide what kind of therapy is the right one to kill the MRD or block it. Then I think that it's important to know that the molecular composition can shift during the surveillance period. So originally we analyze the primary tumor and design specific probes, but in some instances, for example, the chemotherapy can actually select for certain tumor cells that were there just in a minor subpopulation and now expand, and we have to keep that in mind. The assays need to be validated and harmonized. This is very important because if you bring a test into the clinic, you need good quality assurance, and the ALPS is doing a nice job in that regard. And we will also establish that further with the Guide MRD. And I think last but not least at all, we need more interventional study to demonstrate that the early detection of MRD leads also to improved clinical outcome. And I think this is super important because in order to convince the payers to really reimburse this, they want to see how can we improve medical management of cancer patients, and that's what we call clinical utility. The next one, please. And this shows really in which areas we are now looking for clinical utility with the liquid biopsy assays. We have the cancer screening detection and early diagnosis, the preoperative risk assessment and prognosis, which I think is something very important to see whether the disease is more or less aggressive. Then the detection of minimal residual disease. I talked about that today. Then also we can use the test for treatment selection. We can identify therapeutic targets and resistant mechanisms, and that might be very important to the personalized individual treatment of cancer patients. And we can use sequential blood analysis before, during, and after treatment to assess the response to treatment. And we are working with the EORTC RECIST group to actually expand the RECIST criteria beyond imaging. Next one, please. Thank you. I think it was really my pleasure to present the project here today, and I'm happy to answer any questions that come into the chat.
Thank you very much, Klaus, for this very interesting presentation about liquid biopsy. We could learn a lot about what are the clinical utility and what the Cancer ID has done in the past and what is doing the Guide MRD project in the field. Thank you very much. So now moving on to the last project presentation, which is IMAGIO. IMAGIO is focused on interventional oncology, and it will be presented by Robert Hofsink, which is working at Philips, and he is the project coordinator of the IMAGIO project. And it will be also co-presented by Kosje Verhagen. Kosje is a medical doctor. She is a PhD candidate in interventional oncology at the Leiden University Medical Center. Robert and Kosje, the floor is yours.
Thank you very much, Usama. Thank you for inviting the IMAGIO project to this important webinar, and we are happy to share a few words on the project and its ambitions and intermediate achievements. So what I will do, I will present a short highlight of the overall project, and then Kosje will do a shorter spotlight deep dive session on one of the clinical areas in the project. So IMAGIO is about interventional oncology, and this is considered a new pillar in the field of cancer treatment. So you may be familiar with the medical pillar, medical care, which is about the typical chemotherapy that is being used to treat cancer patients. The surgical pillar is about the surgical resection of tumors from the body, and the radiation is typically the external radiation to expose the tumors with a high radiation dose to also kill the tumors. Interventional oncology is a new field, and if you go to the next slide, it is about a few characteristics. First of all, it is a minimally invasive technique, so it has a minimal impact on the patient. Another characteristic is that it's typically image guided, so you need medical imaging, think of X-ray imaging, ultrasound imaging, MR-CT imaging, to navigate in the patient's body to deliver the treatment. And the treatment is done either through the skin or via the blood vessels. So the access to the tumor is made via a very small incision or a puncture through the skin. And the destroying techniques for the tumor, well, there are several. The main are the very local administration of chemo or the very local administration of radioactive particles. And it can also be done by locally heating or freezing the tumor tissue. Next one. So there are some clear benefits of this new technique. First of all, as the name already said, it is a minimally invasive technique. You only require a very small incision, so it also comes with fewer complications and also less pain for the patient. It is a very attractive alternative to open surgery when this is not possible for the patients if they are too weak. But it can also be used in combination with other techniques. So a joint treatment will then lead to an increased treatment efficacy. And in the end, it shows a faster recovery, a short hospitalization, and then in the end also leading to lower healthcare costs using it. So the overall project objectives of the IMAGIO project is to develop several technologies, hardware and software technologies, and demonstrate the benefits of them in three cancer domains: in liver cancer, lung cancer, and sarcoma. And the consortium brings together a mix of highly established technology innovators in the medtech domain, as well as the pharma domain, working closely together with a variety of academic clinical centers and patient representatives, all together setting up a very well-balanced consortium. So the next slide, please. So this shows how the overall project is set up. It is structured along 4 pillars, from left to right, also mapped on the objectives, to develop solutions for radioembolization therapy for liver cancer, as well as multimodal liver ablation therapy. The third one is about the whole care pathway in lung cancer care, and the fourth pillar is about MR-HIFU, and I will come to that for the treatment of sarcoma. Each of those pillars rely on the developments on advanced imaging technologies, as well as usually AI-based image processing for the diagnosis and treatment planning and treatment delivery. It also relies on the image-based guidance during treatment delivery, and all of those 4 pillars will be seeing 1 or more clinical validation studies to demonstrate the value and benefits of them. So I will go into one of the objectives, each of the 4 objectives briefly. So the first one, and this is a brief explainer about what is radioembolization and liver cancer. What you see here is an animation on the left of how this is being executed. And it is about the very local administration of radioactive beads through the blood vessels, very close to the actual tumor. The radioactive beads deliver then very locally a high dose of radiation and then killing the tumor over time. And on the right part, you see some example images that interventional oncologists use to navigate to the exact location of the tumor in the body. The next one. So within the IMAGIO project, the team has been working on an advanced imaging system that combines the 2 imaging techniques that are needed to deliver this treatment. So first of all, you need to know where you are, and that is the anatomical imaging relying on X-ray, as well as nuclear imaging to visualize the delivery of the actual radioactive beads. And that currently is executed in a workflow that spans from planning, visualization, treatment preparation, as well as treatment in the end, spanning over a longer period, taking up maybe 1 or 2 weeks. The ambition of this trial within the IMAGIO project is to bring that all together in 1 imaging system, and also perform the planning, visualization, and treatment in a one-stop shop approach, and then shortening the total procedure for the patient from 1 to 2 weeks in the order of magnitude of a couple of hours, which is of course a tremendous benefit for the patient, and also relieving him from a lengthy process of undergoing the treatment. Next one. So the second one, that is about the thermal ablation. This is one of the other methods of treatment delivery. Also here, a brief explainer. So the image on the top shows the animation of the location of the tumor. And in this case, a needle is being inserted through the skin and under image navigation, exactly positioned in the tumor area. And when that has been accomplished, heat is being applied through the needle, and in that way, locally destroying the tumor while sparing the surrounding tissues. So this is also a very minimally invasive and beneficial technique, also for which several developments are also still required. That's being shown in the next slide. So within the IMAGIO project, we are in the process of developing software solutions very much based on AI and training on large data sets for the segmentation of the liver, the tumor, and the ablation zones, so where the heat is being distributed. So that is about giving guidance to the interventional oncologist for the treatment planning and the treatment delivery, as well as also here data-driven AI-based tools to have a better insight in the treatment outcome and follow-up strategy. So in all aspects in this treatment technique, AI and data-driven solutions are very much supporting the execution of the treatment delivered by the interventional oncologist. Next one, please. So the third one is about the lung cancer care stream. In this work package in the IMAGIO project, various aspects are being developed, and I have picked out two to highlight here. First of all, a lot of data has been collected, imaging and patient data, to develop clinical decision support models to again have a better insight in the treatment outcome as well as the effectiveness and cost effectiveness of the chosen solution. Also benefiting the physicians in the optimal selection of the treatment. And a very impressive hardware solution is currently prototyped as a novel microscope that is able to do analysis of biopsy samples in a very, basically in a real-time fashion, where at present such biopsy samples need to be brought to the lab for analysis, and then a couple of days later you would have the results. Here, within a couple of minutes, so that's intra-procedural, you will have the results of such biopsy samples, again also delivering a one-stop shop approach in the lung cancer treatment. Last one. So the fourth pillar in the IMAGIO project is about HIFU. This is an abbreviation for high intensity focused ultrasound. Again, brief explainer. This is a non-invasive technique where ultrasound waves are focused in such a way that they target exactly at the tumor region within the body. Also here, locally heating the tumor and killing it while sparing the healthy tissue surrounding it. So also a very interesting and non-invasive way of treating the tumors. Next slide. So within the IMAGIO project, we have further worked on the integration of this HIFU device under MRI guidance, so the integration of both techniques. And also here, AI-based algorithms have been developed and being trained and evaluated for the automation of treatment planning, so to assist the physician to determine where to get, how to get to the actual location, and how to also position the HIFU treatment equipment. So that will lead to a very more simplified workflow for the physicians, as well as also a better treatment reproducibility in the workflow. So here, Koosje will take over and do a brief spotlight on one of the areas in IMAGIO, being the liver ablation.
Yes, thank you, Robert. So within the IMAGIO project, we focus on the multimodal ablation therapy for the treatment of liver cancer. Next slide, please. Why liver cancer? So the tumors origin mostly from two sites. The first is from the liver itself, and it's projected to become the third leading cause of cancer-related death by 2030. And this increases mostly due to the aging population as well as poor dietary habits. The second main cause for liver cancer originates in the bowel, so it comes from bowel cancer and then it spreads to the liver. And also this is projected to increase with 800 to 900,000 new cases per year by 2040, with a 5-year survival rate of 40 to 50%. And this is also mainly due to the aging population as well as our current dietary habits. Next slide, please. So when treating the, mostly early stage liver tumors, the main consideration is to choose between surgical resection and thermal ablation. Surgical resection was the standard of care. However, recently thermal ablation has become the most prominent and first treatment of choice for the treatment of these tumors. As mentioned by Robert, it's heat-based and it's minimally invasive. Thereby, it's associated with fewer complications and lower death rates when comparing to surgical resection. It's cost-effective. It has little contraindications, so a lot of patients are suitable for this treatment. The average hospital admission days are 1 to 2 days, so it's quite short. And currently we apply a maximal tumor diameter of 5 centimeters, which might be the only disadvantage. However, it's increasing over time. Next slide, please. So the clinical pathway of a patient that's being treated with thermal ablation is that at the day that he's admitted to the hospital, he's brought to the intervention room. Then general anesthesia or sedation is applied. We try to find the tumor by use of imaging, so that might be ultrasonography or CT. And then we plan the needle, so we stick it through the skin towards the needle, towards the tumor, and we burn the tumor, thereby ablating it. And once that is done, we make an additional scan to check if the entire tumor is treated. And most of the time, the patient is being discharged 1 day after the procedure. Next slide, please. So despite its main advantages, we've noticed that thermal ablation is not often the treatment of choice, and that is a consequence of diversity in outcomes across different centers and countries. So to obtain this, to challenge this, we have organized at the kickoff of Imagio a focus group discussion with the European experts in the field, and we discussed the current role of thermal ablation and its future perspective. Specifically to obtain comparable excellent outcomes worldwide. Next slide, please. In addition, we set up the clinical trial within the Imagio project, and it's within the Netherlands, but also within in Europe in a lot of countries. And we obtain large-scale data and analyze it to identify the best practices of the procedure and also evaluate the efficacy and its safety of thermal ablation itself. Next slide, please. This in turn will help us to guide in decision-making for personalized treatment. We're developing AI-based algorithms that allow optimized procedures. We're also developing AI-based algorithms that allow automated treatment evaluation, and we're designing computational models to identify patients at risk of recurrence to, well, collectively lead to a more standardized, partly AI-driven approach with the goal of, next press please, to obtain comparable outcomes worldwide, eventually leading to thermal ablation as a treatment of choice for the majority of liver tumors worldwide. So in summary, on the entire Imagio consortium, we can state that interventional oncology uses image guidance for minimally invasive treatment of cancers for a patient. The benefits of it are fewer complications, faster recovery, shorter hospital admissions, and cost effectiveness. The Imagio project aims to deliver impactful results in the areas of imaging and AI-supported treatment. And the Imagio specifically will accelerate the adoption of multimodal ablation therapy as the first-line treatment of liver tumors. Thank you for your attention.
Thank you, Robert and Koosje, for this very interesting presentation on interventional oncology, which is a minimally invasive technique, as you've shown us, with fewer side effects, which is more precise and is also cost effective. Now it's time for the Q&A. So we have already received questions in the Q&A box, but you can still ask questions if you still have questions about, of course, Imagio, for instance, that you just have heard about. So starting with the first question, which is for Pioneer and Optima, Susan. Can this data help to address early detection opportunities? Specifically, could Pioneer provide surrogate endpoints so we could assess early detection methods? This is a question from Jonathan.
Yes. Thank you very much, Jonathan, for the question. We could actually do this. We haven't done it yet, but we could try this with the underlying data that we have for the empirical decision support that we have, the tool that we're developing, where we can really try to detect the progression at certain visits. And this would mean that we're building like a predictive model. We're predictive modeling. And like I said, we haven't done it yet, but this is something that I can put out there that they should try. I mean, doing surrogate endpoints is absolutely something that's necessary sometimes. being able to incorporate these to be able to see how, characterizing who's going to get cancer in any cancer form and things like that is absolutely necessary. And some things maybe in our projects we haven't thought of doing yet, so or we haven't had time to do them yet. And if we find that this is something that is most important, then it's really nice to hear your thoughts so that we can actually incorporate them in what's being built right now, because it is possible.
Thank you, Susan. We now have a question for you, Klaus. Colorectal cancer patients are categorized in different groups according to their mutational burden, stable and unstable, or patients from both categories sampled? The questions from Joanna.
Well, definitely we will do this categorization also in our Guide MRD project, because this may also affect, of course, the future therapy options. And it will be also interesting to see whether the MRD status is affected by these measurements. So very good question. Thank you.
Thank you, Klaus. A question for now, again, Optima. So Optima looks very impressive. So first, good comment. When I mention AI tools to doctors and healthcare providers, they are still they are all enthusiastic, but they say that they don't trust. It seems to me like there is a gap between cutting-edge tools like this and their acceptance by doctors. I'm involved in guidelines and development, and most of the panel are highly resistant for inclusion of newer evidence. I feel like the cutting edge moves ahead faster than the profession's moves, so the gaps only gets wider. Can you comment on this?
Yes, I feel your pain when you're discussing this, because they do say, yes, I love it, but I don't really trust it. And I completely understand that. And that's why when we're developing these systems and we're developing these new tools, we really need to have all stakeholders involved. We really need to talk with the clinicians, talk with guidelines, talk with patients, because trust in these tools that we have comes with education of how they were developed in the process, not just me saying, I have this great tool, just use it. The clinician who's using these tools needs to be able to understand where they're coming from. And when we're building all these, and we're building very specific on, say with the guidelines, we're building them with the European Association of Urology's Guidelines Office. So we're finding what is going to be accepted and what is not going to be accepted. But then you have guidelines, but then you also need to take into account policymakers and individual countries where they're looking at how are they going to interpret these and how are they going to allow the recommendations to be based on AI tools. So I think the more we educate on how the answer is received, what data are we using? I have my background also as a medical advisor at a big pharma company, and I also got these questions. And one of the questions when I'm in Europe and I'm presenting data based on the States, they say, how is this for my European men? And that's true, and that's why we need these projects in Europe, and we need data collection in Europe. And then when we're building them, we need to build them with all of our stakeholders so that everybody knows the process, that we're not just pulling data out of the air, that we're pulling that we're using real world data. And it's getting easier and easier the more that we're harmonizing the data to where we can work together. But the trust is going to come with education on how we're collecting the data and how we're using the data and how it's being presented out, is how I feel on this. I think there's a lot of other AI guys on here that maybe has an idea on the trustworthy and how to really build the trust of using AI and the trust of clinics and providing us data so that we can, it's a back and forth process because we actually need the data to be able to develop these tools. So I hope that answered the question.
Yes, clearly. Thank you, Susan.
Maybe add to this, Usama.
Sure, Robert.
Yeah, I recognized the question. I think it may also depend on the physician that is being asked about the utilization of AI. Some are maybe more adoptive of such new technologies. But in any case, when developing such data and AI-driven applications, you need to make sure anyway that the trustworthiness and robustness of the algorithms is in place. So that always requires, of course, data to train any algorithms, and also go through a thorough validation process before releasing it to physicians, because if you release such AI-driven tools too soon and does not deliver, then indeed you will lead to some distrust of such applications. So it takes a very careful process to release such AI-based applications. But in my experience, also talking to some physicians, I notice also that quite a few are very positive and also see the strength and benefits of such AI-based applications.
Okay, thank you, Robert. That was also part of the comment of Jonathan, that they are all very positive with this kind of new tool. So while you're at it, Robert and Kusia as well, there is one question for Imagio about thermal ablation. Can thermal ablation be envisaged to treat other type of cancer types besides liver cancer?
Maybe you can take that question, Koosje.
Yes, thank you for the question. Yes, I think thermal ablation, as mentioned by Robert, can be done by heating or freezing. And both techniques are often used for other tumors, and I think it's expanding over time. So we see now that more and more tumors are being treated with these techniques.
Thank you very much, Kusia. Now, questions for you, Klaus. A question about the focus of Guide MRD. Why is the project solely focused on circulating tumor DNA and not on other circulating biomarkers such as circulating tumor cells?
Yeah, I think that the focus on circulating DNA is actually derived from quite a few data and also assay providers, also commercial assay providers in that field. So I would say it has a bit of a head start, but of course we have also very interesting data, for example, in breast cancer, that CTC measurements can also indicate MRD. And we are including that in a large-scale German study, which is called the SURVIVE study. So here we focus, we have ctDNA combined with CTCs, combined with tumor markers. So it's a more holistic approach. But in the Guide MRD, I think we have already so many different technologies for ctDNA that we are now benchmarking and testing, that I would say that the project would be, kind of exploding in its complexity if we would add other markers. But I think we are collecting large amounts of blood, and I think that it might be also good to keep some of this blood for other analytes if that is possible. But again, the ctDNA field is already so complex, and benchmarking all these different assays and then testing them in our validation clinical trials will keep us quite busy. But I fully agree that a combination marker, not only including the ctDNA, is really something for the future.
Thank you very much, Klaus. I think we have a follow-up question on the one I think that Susan, you responded to, but I think it applies to every project, is about education. Can patients and patients advocates play a role here in educating everyone? I feel we often have access to people in ways that a formal project may not have. So maybe you may start, Susan, and if someone else has additional insight.
Absolutely, patient involvement is it's very big, and it means a lot, because when we're deciding and we're looking at what are gaps in knowledge, if you look at what a clinician finds as a gap and most important, when you talk to a patient, what they find is most important could be completely different. So we need to actually, I think that's what's really good with these innovative health initiative projects, these public-private partnerships. I believe all of us have patient advocate groups and patient groups involved with us, so that we're not just pushing off, okay, this is what we're doing, this is what we see is most important. To have a patient actually come in and say, this is my journey and this is what happened to me, this is a lot stronger and can actually turn how you look at the development of some of the platforms that we're developing. We can adjust based on this because it is the patient that we need to listen to. Sometimes we have these great therapies that maybe have adverse events, but as a clinician, you'll think, okay, maybe that's fine. And a patient, no, I want to wait. What are my options if I wait? And we need to be able to give him or her those options. And in order to do that, we need to be able to talk to the patient. We need to have patients involved as much as possible to come to us and say, listen, this I'm not finding a problem, so why are you working on this? This I'm finding a problem, so help us. So I think with all of these public-private partnerships, I think that it's so great that we have patients involved, and I hope that we involve them enough, and I hope that they, keep voicing what they feel strongly about.
Thank you, Susan. And while you're at it, just a question about Optima AI tool. Is it a new tool with respect to other existing on the market? It's from Valentina.
Yeah, the AI tools.
Yes.
There are a lot of AI tools being developed, of course. We're very specific on what we're looking at in Optima. We're very guideline specific, looking at the patient pathway. And one of the really good things that we're doing is we're building this on using multimodalities and multimodality data, meaning that we're using data that's been put into this OMOP common language, but also non-OMOP. So more imaging and that. So it's multimodalities, but then within Optima, we're integrating NV Flare. And this, I don't know, I'm not working on this part. This is not my expertise, but this is something that we're integrating in that will help us do analysis and build this platform a lot safer and a lot faster. But I think that it's the multimodalities from a lot of, when they're being built on these projects, a lot of them are very specific. We're very specific on cancer types. We have prostate, breast, lung cancer. So they're being very specific, and we have exactly what we're looking at. We're wanting pathways based on guidelines. We're wanting living guidelines. This is what we are. So we are unique in that sense. So.
Thank you, Susan. Question for Imagio. It's related to the slide when you mentioned discussions between experts about the use of thermal ablation in the clinical practice. What are the next steps and the main barriers for making thermal ablation a standard of care treatment in clinical practice for liver cancer, if it's not already the case?
Thank you for the question. So I think within the focus group discussion, we tried to explore what the current hurdles are. So why is there so much diversity? And I think we can split it into 3 phases. So you have the patient selection. There's a lot of diversity in the tumors that are being treated. The next phase is the procedure itself. So we see that there's a lot of diversity in the way that the tumors are being treated, and most of all, the treatment evaluation is important. So that's the phase after the ablation, that you check, is my procedure successful and did I treat the entire tumor? And we try to identify what would be the best structure to make it more standardized, to reach a certain basic level of success across all centers that is reachable for everyone. So some hospitals have a lot of advanced software and others don't have them, but still we need to reach a certain level of success to reach the goal of making it the treatment of choice.
Thank you very much, Kossie. Now a question for you, Klaus. For GuideMRD, so what are the cancer indications that are the most relevant for liquid biopsy clinical implementation, and why?
Well, in GuideMRD, we choose 3 cancer types, colorectal, pancreatic cancer, and lung cancer. And we choose these entities because of their general relevance. These are major tumor types. I should also say that pancreatic cancer will be in 2030 the second leading cause of cancer-related deaths. So it's really frightening and increasing. So we choose these three tumor types also because they have, let's say, three different speeds of relapse, so to say, and we will see whether the MRD detection is more effective in more rapidly or less rapidly progressing tumor type. That will be also super interesting. So that was the reason. We would have loved to include even breast cancer and others, but I think, again, you know, if we make a project too complex, then we are not able to achieve our goals. So I think it's already quite challenging with these three tumor types, but MRD detection is certainly also interesting in breast cancer, another big tumor type, and maybe also in other tumors such as melanoma, skin cancers, and others. But we had to focus. I think that the MRD detection will open a totally new avenue for interventional clinical trials in various cancer entities, and we have called them post-adjuvant trials because that allows us not only to treat patients at the diagnosis or when they are becoming metastatic, but it may allow us in between to treat patients that are MRD positive, and that concept is applicable to literally all tumor types.
Thank you, Klaus. Now a question for you, Suzanne. For Pioneer and Optima, what is the estimated timelines for finalizing, testing, and maybe deploying the clinical decision support tool you mentioned during the presentation for both projects?
Well, the first one from Pioneer to Pioneer Plus, we're still developing. We had for the patient experience tool, the empirical support, we actually did we trialed it at the European Association of Urology conference in March, I think it was. So we've already started trialing that. So we're building on it, and it is with test sites because, like what was mentioned a little while ago, you don't want to put stuff out before you know if it's ready and what you can use. But so we're starting to trial that, but not openly. So I don't have the timelines when they're going to finish. For Optima, we have, I think, a year, 2 years, a year and a half left. Then we're going to start on sustainability for that. And we're already working on the sustainability plan. My hope is that, like with Pioneer, and we're going forward with the tools that we built there, that we keep going forward with the tools that are built in Optima. So we're working on sustainability now. It could be that it goes like with Pioneer, where we go forward with a large society that supports the cancer types. It could be other sustainability plans, but the goal is that it does not stop. That I don't think that we will have a functional tool at the end. I think that we will have the foundation. And remember for Optima, we're working for 3 cancer types as well. So we're doing our best to get all 3. A lot of the techniques can be used across, but individual, like mapping for the individual cancers, it takes time to do that and to make sure that the mapping is correct and that the support is there and that the data that is there that we need. So these take a lot of time to get the data in the form to use. And then it takes a lot of time. Once you have something you think is great, then you trial it and a clinician's like, oh, I would never use this. Look at how hard it is to get this, or I can't explain the results. It takes a lot of time to do it. And we're hoping that the new tools that are available, like with the NV Flare, that these will help to make this a quicker process that's more acceptable and more explainable. I don't have the timeline exactly when it would be out, though. I'm sorry on that because they're going at different times.
Okay, thank you, Susan. So we are reaching the end of this event. So we've heard today project presentations about what IHI projects are doing in the field of big data for prostate cancer, but also in AI, developing a decision support tool with Optima, and also being able to, in a non-invasive way, to detect early relapse of cancer with guided MRD and liquid biopsy. And also, at last, the last project presented with interventional oncology, and its utility in clinical practice that we could see with the thermal ablation in liver cancer. So it was really an impressive presentation. I would like to thank you all for your presentations. Obviously, there are other projects, IHI projects, that that we can learn about on our website. We have a project working on theranostics or proton therapy and many others. So we really invite you to visit our website. I would like to thank you all for attending this event, for the questions asked. And I would also like to thank my colleagues from the communication team, Nassima and Catherine, who have been instrumental in organizing and running this event. So thank you all for your participation, and see you next time. Thank you.